I am a radiation oncologist. As Dr. Chody said, recently was working at UT Southwestern, so it's also nice to be back in Dallas, a place that I called home for about 8 years. It's kind of delayed here in terms of... Okay, so the purpose of today's presentation is somewhat limited, but I just wanted to touch on some key aspects of the role of radiotherapy or potential roles of radiotherapy in gastric cancer management and some of the controversies. So really want to touch base on what the contemporary role of radiation therapy is in the management of gastric cancer. I do want to note, I think this is already obvious, that we're primarily talking about gastric adenocarcinomas here. And my talk will also be primarily focused on true bona fide gastric cancers and not gastroesophageal junction cancers. I think the role of radiation therapy in GE junction cancers and certainly esophageal cancers is less controversial than its role in bona fide gastric cancers. And I do want people to remember that radiation does play an important role in more uncommon types of gastric tumors, such as certain types of lymphomas, like diffuse large B-cell lymphomas, where it's often used as a consolidative therapy following chemotherapy, and also sometimes as definitive therapy for MALT lymphomas or marginal zone lymphomas of the stomach. So one of the things I like to discuss with residents when we're teaching them in the clinic and medical students is we have to think about in cancers that are primarily managed with surgery. As Dr. Chody said, surgery is typically the primary definitive local therapy or curative intent therapy for patients with gastric cancer. We have to ask the question, is there a role or a rationale for radiation therapy? And when should we consider adjuvant local radiation therapy for cancer? And I think a general model that's applicable to all sites within the body that can be considered for this is to consider the following functions. Really, what is the risk of local regional recurrence when surgery is incorporated? Okay. What is the risk of distant disease occurring, which is going to limit the value of an adjuvant local therapy in general terms? What actually leads to cancer-specific death? Can local regional recurrences actually lead to mortality for patients? How sensitive, of course, is the tumor to radiation therapy? How good are the systemic therapies that we have available for that disease? And then finally, how toxic is the radiation therapy going to be for the patient? So it's one thing if it does a great job at eradicating either gross or microscopic amounts of tumor, but if it's a very toxic treatment, and certainly if it leads to patient deaths or severely impacts quality of life, the real therapeutic ratio for that tumor may be quite marginal. So to answer that first question, what is the risk of local regional recurrence? This is an older paper. This is one that's classically cited by radiation oncologists because it was provided a lot of justification for the role of for the use of radiation therapy in treating stomach cancer that had been operated on. There's a classic reoperation series that came out of the University of Minnesota. It was a combined publication of a radiation oncologist and a surgeon. And that actually did demonstrate very high rates of local regional disease recurrence after so-called definitive radical surgery for gastric cancer. Now, this was, from patients who were operated on in and before the 1980s, before these concepts of, more extensive lymphadenectomies were considered. But nonetheless, this paper did spur a lot of interest in using radiation as an adjuvant therapy to surgery, and it's a very rational thing to consider. Intensive dual local therapies in this type of scenario. Okay, so what are our standards in 2017? Well, to start with, this is not intended as an intensive overview of all the recent randomized trials, but really there were two studies that were published actually many years ago now that helped establish what our standard is for local regionally advanced gastric cancer. And both of these studies did indicate overall survival benefits, and so they were widely accepted in the oncology community. But they really came at the problem from different perspectives. So the Intergroup study was a study that randomized patients who had had gastric cancer surgery to basically observation versus adjuvant chemoradiotherapy and subsequent further chemotherapy with a single agent. And then there was the MAGIC study, which looked at the role of so-called perioperative chemotherapy. So patients were randomized to surgery or some chemo before surgery and then the same chemo after the surgery. Both of these studies showed an advantage, or an overall survival advantage to the intervention. So both of these kind of became competing points of view to the problem of adjuvant therapy. Seems to come up faster over there than the Spanish version. Okay, so what was the Intergroup study? It's important to realize that a lot of so-called stomach cancer studies really involve a hodgepodge of patients, so not just true stomach cancers, but also patients with GE junction cancers. And again, these may be different beasts biologically, but nonetheless, these are often grouped together in randomized trials. And again, the randomization was to just watching the patients after their surgery, so observation versus intervention with concurrent chemotherapy and radiation, the radiation given over 5 weeks, and then further chemotherapy. And what the study showed is that the radiation was doing kind of what we would think it would do. It did seem to reduce the risk of local regional recurrence. And as I said before, there was a apparent survival advantage out at 3 years of about 10% in favor of the adjuvant treatment group. This study has been criticized. For one thing, it wasn't a true test of radiation or chemoradiation, as the patients also got further chemotherapy following the chemoradiation course. And then, of course, this issue has often come up and has already been touched on by Dr. Chody and others as to whether or not the surgeries that were done in this group were inadequate. The recommendation was that the patients undergoing gastric cancer surgery should have more extensive lymphadenectomies, or the so-called D2 surgeries, but really a very small minority of the patients had this. So some people have criticized the study and saying that the chemoradiation role was really to make up for the inferior lymphadenectomy. What are some other important studies to know, or other trials to know that have come out in the years since the Intergroup and the MAGIC study? Well, so the ARTIST study was an attempt to really answer this question: does adjuvant chemoradiation play a role in so-called optimal surgery? Okay, so patients who have undergone a true D2 lymphadenectomy, and these patients were randomized, this was a study done in Asia, and these patients were randomized to adjuvant chemotherapy, so surgery plus chemotherapy, versus surgery followed by chemoradiotherapy and chemotherapy. So it's really addressing both of those two main criticisms of the Intergroup study that I just mentioned. So what are the results? Well, the study's been published and has actually been updated as well recently. And what it showed was kind of a mixed bag. There was a borderline disease-free survival benefit to the use of chemoradiation that the authors in subgroup analysis thought was most strong in patients who had lymph node positive disease and also intestinal type tumor, so a specific histology. And this is now being further studied in the ARTIST-2 trial, so it's a patient selection for patients who meet those criteria, node positivity or intestinal type tumors. The CRITIC study is also in the works, and this was basically following preoperative chemotherapy in the form of MAGIC style type of chemotherapy. Patients are randomized to adjuvant chemoradiotherapy or MAGIC, further continuation of MAGIC. And really, this study has been published and it showed no difference in progression-free or overall survival. It is worth noting that only about half of the patients actually got the full protocol therapy. An indication that in a cancer such as this, which often requires a major surgery, gastrectomy, that delivering full adjuvant therapies can be somewhat challenging. There's also the Top Gear study, which has not been published in full yet, but essentially this is the MAGIC type of regimen versus the integration of preoperative as opposed to postoperative chemoradiotherapy. I think some of these early surgical toxicity results have been published, and this question came up earlier from the group as well. And there's actually no differences between the two groups in toxicity outcomes, including high-grade postoperative surgical toxicities. So it seems that chemoradiotherapy can be given safely prior to a gastrectomy, as opposed to just giving chemotherapy itself prior to gastrectomy. So we'll await the results of this to find out if preoperative chemotherapy has something to add to preoperative chemo by itself. Some other trials to know, there's the FLAT4 study. This randomized patients to the MAGIC regimen versus a newer triplet drug regimen, FLAT. Again, the study had a hodgepodge of patients. Some of them had gastric cancer, and others had tumors straddling this esophagus and stomach. This actually did show improved survival with the FLAT chemotherapy. So this may supplant the ECF regimen or the MAGIC style regimen going forward, as it appears to be a more active and more effective regimen for patients, which actually leads to improved survival. The toxicity was similar between the two groups. Okay, so how do we summarize all these studies that I've mentioned? Again, it's a little bit dicey because some of these studies included patients with GE junction cancers as opposed to true bona fide gastric cancers. I think that we can safely say that even in the setting of quote unquote optimal surgery, so more advanced or more extensive lymphadenectomy, as well as systemic therapy, that chemoradiotherapy may provide a modest but meaningful benefit to patients. And this is primarily based on the ARTIST results, and we'll see what the results of the ARTIST-2 trial are showing. The Top Gear study is asking a very clean, single variable question. And the nice thing about that study is that the radiation is delivered pre-op as opposed to post-operative. As a radiation oncologist, typically we like to treat, if we're going to incorporate radiation into the care of patients who are going to have that organ removed, from our perspective, it's often much nicer to be able to deliver that radiation prior to the surgery as opposed to afterwards. And there's many reasons for that, not the least of which is the simple practical matter that it's nice to be able to target something. Okay, when you're treating in the postoperative setting, you're treating somewhat what is often an ill-defined tumor bed. And it's not very satisfying, and there can be variability from radiation oncologist to radiation oncologist as to what the target actually is. Whereas when you have the tumor and it's visible on a planning CAT scan, it's hard to miss the tumor. There's other reasons as well, including tolerability of the therapies. So if Top Gear does show an advantage to integrating chemoradiotherapy in the neoadjuvant setting, I think that'll be very interesting results. Okay, so what are some of the remaining questions that we have to consider with regards to the role of radiation therapy in gastric cancer management? Wait for my, okay. So, what are some of the questions and also some of the issues with the published results so far? So really none of these studies that I've mentioned enriched for patients who are most likely to benefit from the treatments, okay? So it comes down to the issue of selection and selection and selection, okay? Because frankly, we still aren't really smart enough to know how to properly select patients for therapies that they might benefit from the most. So we tend to group patients together, we tend to group patients even when they're anatomically in somewhat different locations. The ARTIST study, again, showed the most benefit for node-positive patients in intestinal-type tumors, so maybe that's an early way to start to select patients. And really, again, I think the more focused selection will be used going forward in clinical trial design will probably give us the most meaningful results for our patients. Whether or not genomic markers, or genomic signatures, I should say, will be able to outperform things that we already use, such as clinical pathologic features. Simply, is it node positive? What does it appear like under light microscopy? we'll have to determine going forward. But I suspect that will be the future of gastric cancer management. So a little bit about the technical challenges with radiations. I already mentioned that we'd prefer to treat a tumor that we can see. It's often a very challenging tumor to treat, as is any abdominal tumor, because there's a lot to it for us to avoid. Okay, there's a lot of prime real estate in the neighborhood. You got your kidneys, you got your liver, your spinal cord and cauda. You have the bowel itself, and something that you may forget about, which is the stomach itself as well, which can be very much a dose-limiting structure for us when we're trying to treat these patients. The acute toxicities are often, they're real, but they're often very manageable. It's often very much a team approach between the physician, the nurse, dietitians, social workers, and so on. And late toxicities, again, are really the things that keep the radiation oncologist up at night, and that's what we're really trying to limit, and respecting the tolerance of those organs that I've mentioned above. It's challenging to treat the stomach too. Okay, so the stomach moves, obviously, as we breathe with diaphragmatic motion. It's also a distensible organ, so you're trying to treat a moving and deformable target. Okay, and so if you're trying to get fancy with your radiation treatment, you may miss the target. Okay, how do the radiation oncologists deal with this problem? Well, one thing that we do is we add margins. Okay, we add so-called safety margins. But as you increase the size of your safety margins, it's going to mean necessarily that you're irradiating more of those normal structures that I mentioned above, and that's not a good trade-off often. But really, it is this trade-off of delivering proper dose to the tumor and avoiding overdosing of normal structures that really comes into the art of what a radiation oncologist does when treating gastric cancer, or frankly, any type of cancer. So what are some of the solutions to these problems? To manage the motion problem, we can gate the treatment, meaning that when the tumor, which is, let's say moving superior and inferiorly, when it's in a certain location, the beam will be on, and when it moves out of that window, the beam is off. Okay, that's one solution. That's rather labor intensive. The patients can hold their breath during the treatment. This is something I like to use quite often if patients can tolerate it, because that essentially ceases any type of motion, and then you have a static target that you can treat safely. We use image guidance when we treat patients, so we'll often use cone beam CAT scans with the patient on the table to image where the tumor is and how full it is prior to the treatment. And we can also image any surrounding targets that we want to treat, such as lymph node basins. Image-guided therapy also allows for what we call adaptive therapy, which allows us to change our treatment margins even during the course of therapy for a given patient if, for example, we think that we've been overly generous with our treatment margins up front. What is the target that we treat with radiation? So traditional preoperative target volumes, again, have been the entire tumor with significant margin, and this is often the entire stomach, along with the regional lymph node basins. So can we do better than that? I mean, if this is something that we've been doing for decades, should we minimize our volumes? There's a lot of variables to consider there, okay? And again, with the distensibility of the stomach and its respiratory motion, it's challenging to treat smaller target volumes, or I should say more rational target volumes. So for at least for the foreseeable future, pretty much the entire stomach and the surrounding regional lymph nodes are going to be targeted. What about radiation dose? So sometimes patients ask about, they've heard about stereotactic body radiation therapy, for example, and really there is a trend in our field towards delivering shorter treatment courses with higher amounts of radiation given with each treatment, okay? That's great, but, sorry, let me go back here. The problem with that is high dose per radiation treatments are often very challenging to deliver when you're treating in a hollow organ such as the stomach, okay? Because the risk of severe consequences such as perforation is a real risk, and thus more gently fractionated radiation therapy is typically how we deliver these treatments. You can kind of think of it as series structure. So if you have a serial circuit, or you can think of it as in terms of circuitry. If you have a serial circuit and you break a connection in that circuit, the whole organ will no longer function. Whoa, okay, sorry, we are skipping around a lot here. Whereas if you have a circuit arranged in parallel, if you knock out a section of that circuit, the circuit as a whole can still function. And that may be like a lung tumor or a liver tumor, where you can damage some of the surrounding tissues without seriously compromising the function of that organ. And really, that's not something that's going to be feasible when you have a hollow serial organ, because you really run the risk of perforation or severe consequences for the patients. High doses and focused treatment volumes may be suitable, so stereotactic approaches may be suitable for example, if you are treating a patient who has a liver metastasis or a lymph node recurrence, and in that case, SBRT may be an option. So there's lots of different possible future directions. I just wanted to mention two of those. Mr. Kuzmin this morning mentioned that in the setting of metastatic disease that he had local therapies applied. So he had electroporation therapy applied to lung metastases, and he had embolization therapies applied to liver disease. So it's rare for us to consider, at least classically, local therapies in patients who have metastatic disease, but certainly the trend of that is changing over time. One of the terms that gets thrown around quite a bit is the state of so-called oligometastatic disease. And that's probably a real phenomenon in selected patients. It's hard to know who really meets those criteria or how to select patients for this. But I think it's, for the current time at least, it's rational to apply ablative radiation therapies or other types of ablative local therapies like electroporation in selected circumstances. So you have a patient who has metastatic disease but has done well on chemotherapy, may have one or two residual areas of persisting disease, and otherwise is declared that they have somewhat favorable biology. Treating those patients with ablative therapies may be very sensible and may be curative. We've heard a little bit about immunotherapies, and there'll be another discussion on that later today. We've heard about pembrolizumab, which is an immune checkpoint inhibitor, and that's shown some efficacy in selected patients with gastric cancer. The question is whether or not that can synergize in combination with radiation. And there's a lot of preclinical data suggesting that you get some type of synergistic anti-tumor vaccination effect when you combine immunotherapies, including checkpoint inhibitors, with radiation therapy. Okay, so moving forward, I think the ongoing clinical trials will better define the role of radiation, okay, with so-called optimal chemotherapy and optimal surgery, at least in all comers or unselected patients. And I do think that radiation will play an increasingly important role in the treatment of selected patients with at least limited M1 disease or limited metastatic disease. And whether or not it's going to play a role in augmenting the efficacy of immunotherapy is something that I think will be needs further evaluation and is an exciting avenue for all oncologists to really investigate going forward. Thank you.